abstinent from drugs, in good health, and a good citizen.
Right on. Questions? Yeah, from.
Me?
Yeah.
Hi, I'm Joan Borston. I'm CEO of the Malibu Beach Recovery Center. So I have a lot of questions, but as we have someone from the government here, I'd like to ask you something that I've been addressing with the California State Legislature. So recently we had a doctor from Duarte who was arrested, and when he was, it turned out that he had ordered personally from the pharmaceuticals 1 million class 2 narcotics in 2008. And when they arrested him, he could account for 250,000 of them only. So what happened to the DEA and what happened to the California, why is this happening? And he's not alone.
Yeah.
I'm very disturbed about these gray areas where.
Right. So first, let's start with the substance. Prescription drugs, particularly prescription opiates, now been declared by the CDC an epidemic. Prescription opiate overdose is now the second leading cause of accidental death in this country. It surpasses car accidents. It surpasses gunshot wounds in a lot of states. That's a tremendous problem. Two, where do these drugs come from? How do they get there? Well, the biggest chunk come from doctors. If I told you that I had a list of the 200 top prescribers of opiates in this country, do you think it's beyond statistical chance that 180 of them would be in Broward County, Florida? It is. It's now the medication center. There are flights from Detroit and Atlanta and a lot of places just to get these drugs. Paradoxically, some of the things that have enabled better use of medications have also prevented the DEA from being able to shut down some of these pain clinics. These pill mills is what we're calling them. But I'm happy to tell you that the DEA, CDC, FDA, and our office are all working together. Within the month, we expect to see changes in legislation that will, number one, require doctors to learn how to prescribe pain medications. Very important. Nobody wants to stop pain medications from being able to be prescribed appropriately. They work when properly applied, okay? But doctors are all over the map in how they prescribe. Over and over we hear from dentists, I just had 2 teeth extracted. Here's a bottle of Vicodin, don't call me. Wrong, okay? So there'll be requirements for doctor training and certification for prescribing opiates, and new methods to get in and stop some of these pill mills. The other area is the internet. The internet is a big source of these drugs.
But this doctor ordered 1 million pills directly from the pharmaceuticals. How did class 2 narcotics, how did he do that and nobody red flagged it?
The DEA has about 175 active agents. It's a big country, and they have to do an awful lot. They have to look at a lot of different doctors. They got to look at a lot of different clinics, and they're overworked. I'm not saying it's right. I'm saying that's the way it's. Yeah.
Other questions on this topic for Dr. McClellan? Yeah.
Well, I'm kind of glad to hear you kind of discuss that, because I think one of the big problems is you have family members, or you have people who they get on these prescription drugs from the doctors, and there's a big question to the family. Well, this person I know is in pain or claiming to be in pain, and yet the doctor's saying they should be using these medicines. How do we inform the public on what's accurate, what's actual pain?
Yeah, pain management. I don't know if you heard the question in the back. How do you reconcile them? What's the right thing to do? Let's say a person has legitimate pain, low back pain's the big one. They also have a history of addiction. What do? Suffer? Probably not. But it takes a sophisticated doctor and an informed family to manage both the proper treatment of the pain, but also the just as Adam was talking about, the chances for that individual of a return to addiction. It can be done, but it takes skill and it takes training that most doctors don't have. Nora Volkoff, who's the head of the National Institute on Drug Abuse and a world expert, said there's two things I never learned in medical school: anything about addiction and anything about pain. As we say in Philadelphia, yo. Bad idea.
Where does the federal government stand on centralizing data for doctor shopping, to avoid doctor shopping?
Good question. I didn't bring it up. You're talking about prescription drug monitoring programs. And now there are 38 states that have adopted a prescription drug monitoring program. What it is really is a registry. So if you go in and you get treated and you get an opiate, it's restricted to opiates, and you get an opiate, you're on a registry. And what that ought to do is prevent you from going 2 doors down to another doctor and getting another prescription for opiates and another. Well, so far they haven't worked. And here's why. One, doctors aren't using them. And in this legislation I was just talking about, they'll be required to. Two, the information takes a very long time to get back, so you can't, it's not instantaneous. Three, if you go, I live in Pennsylvania, so I could go in a matter of an hour to doctors in Philadelphia, doctors in New Jersey, and doctors in Delaware. This interstate exchange has not been there. Those are reasons why it hasn't worked. What we're trying to do is make that possible. Added on top of that is the healthcare reform legislation has asked for electronic health records. That should be instantaneous record of all medications that you're taking. So I think we're going to have a techno fix in the future, but it hasn't been there.
Can you add your story about text ordering?
Oh, yeah, and that's the other. This is a terrible problem. It's what Sandra's talking about is internet access to medications. If you get your Google right here, right now, I did it on the floor of the U.S. I did it on the floor of the U.S. Senate. You can put no prescription Vicodin in there, and you will get pages of places that you can right then, right there, with a credit card, and sometimes without a credit card, get Vicodin shipped directly to your house. Oh, get out of here, Tom. That's like the Nigerian bank scam. No, it's not. When Customs has seized some of these medications, it's the real thing. They're all made outside the country. It is not illegal for them to send the medications to this country. It's illegal for you to get them, but it's very difficult for the DEA to and Customs to police all of that. And so, a lot of people like that. They don't have to go to the doctors then. Let us say reasonable use. I got low back pain, OxyContin works for me. I know what the doctor's going to say. Why should I go and spend $250 when I can just get this over the internet? That's been the thinking.
Other questions? We have a lot of treatment professionals and people in recovery. No, you had one. Hang on. Yes, Mr. Kane.
Doc, hi, my name is Doug Kane. I'm a treatment provider. I hate these. I hear a lot still to this day about the so-called war on drugs. And it sounds like what you guys are talking about is not a war on drugs. When Americans define a war with a goal attached, we're pretty good at kicking butt. So there's never been really a good goal, and you can't get one. It sounds like what I hear you talking about now instead is, as it were, a war on addiction instead, or at least finding effective treatment, therefore. I'm curious less about specific treatment modalities and more about what's the language like? How does it feel? I guess I'll ask Dr. McClellan to you, given where you are and what you hear. Is the mood, the mind, the language at least starting to change? If not, or if so, is there a plan? Is there some idea about how we talk to one another about this thing that we're trying to do?
Yeah. Gil Kurlikowski announced the first thing that he got into office, Bill Kerlikowski's the drug czar. And he announced the end of the war on drugs. It's a bad metaphor. And it really conveyed quite inappropriately a war on people that use drugs. I mean, that's dumb. So what we really should have, and it would be great if Intervention and other Hollywood writers could come up with something snappy that would fit on a bumper sticker. But the problem is, I got bad news for you. We don't have a quick fix. None of these medications Adam was talking about or I'm talking about, they're all good. They're all going to help. We have really good evidence-based prevention programs. We have lots of things that can work, but you know the truth? The truth is we ain't got no cure, and what it's going to take is personal responsibility, families working together, a delivery system that can manage and keep managing what will always, as far as I'm concerned, always be problems. Adam pointed out there are personality issues and genetic predispositions. We were talking at lunch. The first crops ever produced by Homo sapiens were not made to eat or to feed to his animals. They were made to ferment so they could get high. It's in our genes. So what we're offering is a not very sexy tune. It's a new way to manage and take responsibility as individuals, as families and communities, a problem that can be managed but can't be cured. I would love a snappy slogan that would communicate that. I'm not kidding, but that's what we got. That's what we're selling.
Well, we will surely work on that. Yeah.
I
Dr.
just wanted
Leventhal.
to. Is this okay?
Monday at 9.
I mean, I wanted to comment on this idea too. I think so. Some of my work is in smoking cessation, and you know that's not a topic of this show, but you know clearly it's an addiction. It shares something. Some sort of basic overlap with addiction to hardcore drugs of abuse and alcohol. And the smoking cessation field has really advanced by doing some of the things that Dr. McClellan was talking about, by incorporating smoking cessation into primary care. And research suggests that even just 5 minutes or even less than that of your doctor, your primary care doctor saying, hey, you know what, you should quit. If that's done on a massive scale, the public health impact of that is dramatic. And Dr. McClellan was talking about those people with substance use disorders who maybe have developed the full-blown substance dependence diagnosis yet and are maybe just hazardous users. Perhaps if we could train our doctors, as we're starting to do with in smoking cessation, to just a quick, brief intervention, assess, the extent of use, just give some brief advice about the negative consequences and some potential treatment options, that would be worthwhile.
Yes.
I'm sorry. I'm Tammy from A Better Tomorrow, and what I'm hearing I really like. But what I would like to see, I know for us at A Better Tomorrow, in order for us to get paid from the insurance companies, we have a lot of requirements that we have to meet. And so I think that to motivate the doctors to be more apt to give the advice and to refer people out and to do what they should do while they're prescribing the medications, even Campril, all of those things that they're prescribing to people, they're giving, a man comes in, he's an alcoholic, he gets Campril, it says right there he's supposed to have therapy in conjunction with the medication. There's no requirements, there's no follow-up with them making sure that that's happening. I feel like if the government puts some restrictions on the insurance companies on how to pay these doctors, you can get paid, but what's happening with the follow-up? What other treatment's going on? I believe that would help, really help with the situation.
I agree with you, and I think you're going to see changes. 3 things are happening in concert. One is, as was pointed out, a new direction in drug strategy. It's not that we think